52.
Good morning, everybody. First of all, thank you for inviting me to give this talk. And on this occasion, I also wish to thank my trainers, and that includes Prof. Marjan Jahangiri and Mr. Amrani from Harefield and St. George's Hospitals. Before I give this presentation, I want to stress on the fact that the trial is still ongoing. It's not complete yet. The data we have is incomplete at the moment. I spoke to National Institute of Health Research, who sponsors this study, and they are very unkeen for data to be presented. However, when Joe asked me whether I could give some feel about the trial, I thought it's a good opportunity to come and talk. So we all know the aortic valve replacement is the second most common operation performed in the UK. In 2006-07, we did about 3,400 in the country. And there are some studies that report benefit of minimal access aortic valve replacement. There are equal number of studies which have disproved any benefit with this approach. In Papworth Hospital, we do this through a right upper mini sternotomy. The questions we wanted to answer in this trial, which we applied for to the National Institute of Health Research, was whether it reduces length of stay. That was the primary outcome we were looking for. We also want to know whether it reduces postoperative pain, wound complications, blood transfusion requirements, intensive care unit stay, etc. We wanted to know whether cosmetic appearance mattered and patients really cared about it. And finally, whether it was cost effective. So from the NHS point of view, is this something which every hospital in the UK that practice cardiac surgery should be looking into? We thought that if we could reduce hospital stay by 1 day, the NHS might save £1 million a year. And that with mini sternotomy, you might reduce hospital stay and have fewer blood transfusions and other complications like wound problems. We looked at our database, and this was comparable with the UK database. In 2007-08, the mean hospital stay of 252 patients was 11.7 days. My colleagues and myself, we were very surprised to realize that this is actually quite long. We aimed for a 20% reduction. That was our aim, to reduce hospital stay to 80% what it was. And for that, we needed 110 patients in each group, a total of 220 patients. We wanted to aim for only 50% of that number who we thought would be suitable for the trial. And we thought that we would complete this trial in 22 months in a single center. We had very simple inclusion and exclusion criteria. All patients referred for single first-time AVR would be included. We thought of excluding poor left ventricular function patients, significant chest wall deformities when they were morbidly obese and the cutoff was a BMI of 35, and when obviously the patient needed concomitant procedures. It was planned as a prospective single center randomized pragmatic trial. Initially it was just me doing it, but then we obviously wanted to increase the number of surgeons. Currently there are 5 surgeons partaking in the trial, and that includes my colleagues, Mr. Caterino, Mr. Codispoti, Ms. Dunning, and Mrs. Sudarshan. There were 2 problems we faced, 2 unexpected issues. First of all, I thought that this is a technique which any surgeon can do, and I still feel that this is a technique any surgeon can do, but it needs a bit of training. We entered into discussions with the National Institute of Health Research and decided that each surgeon will be proctored on at least 6 occasions before he or she starts recruiting. Now that delayed active recruitment into the trial a lot. The second was patient-related factors. We thought our expectation of the numbers we will have was wrong. In the last 5 years, the spectrum of patients who get referred for cardiac surgery has changed, and the number of isolated AVRs have gone down with a concomitant increase in double procedures, namely another valve to be attended to or coronary artery bypass grafting. Our primary endpoint was length of hospital stay. but we also included another primary endpoint, which was the day of fitness for discharge. As we all know, there are lots of factors in the British system which delays hospital discharge, including that my daughter can't come to collect me today from hospital because she has to attend a party, to many other unreasonable reasons. So we wanted to decide the day the patient was fit for discharge from a medical and physiotherapy point of view. In this trial, that decision is ultimately taken by the physiotherapist. So the medical team declares fitness from a medical point of view. The physiotherapist assesses the patient. We don't interfere in that. And they take the patient for walks up and down the stairs, etc. And when they feel the patient can go home, that is recorded. The patient might actually leave the hospital most of the time the same day, but there are many occasions when the discharge is delayed for other reasons. There are lots of secondary endpoints in this trial. We look at postoperative pain levels, wound infection requirements, and at requirement for antibiotics, peri-op bleeding, health-related quality of life is assessed. The cost of treatment is assessed at various time points. So some of them are in hospital, others in 6 weeks, 6 months, and the longest time point is at 1 year. Today, I don't have the results of all these secondary endpoints. After having long discussions with the NIHR, they have allowed me to present or disclose this much. We have so far only recruited 73 patients. We have got 39 in the ministernotomy wing and full sternotomy 34. Age range is 18 to 88 years of age. We have used 62 tissue valves and 11 mechanical valves in this group. The mean hospital stay is 6.3 days in the mini sternotomy and 7.35 days in a full sternotomy group. Tests of significance shows that this has a p-value of 0.065, so it is insignificant at this point of time. However, as I said, the trial is not completed. We are having a data monitoring committee meeting within the next couple of weeks. And one thing I would like the committee to consider is when the trial was designed, the mean hospital stay was 11-odd days. And currently it is, in the full sternotomy group, is 7 days, and whether that will make a difference to the numbers we need to treat. There has not been any wound complication in the mini sternotomy group. One patient in the full sternotomy group had significant or deep mediastinitis needing re-exploration, vac insertion, and plastic repair. One patient in the mini sternotomy group has been converted to full sternotomy, and that was because the intra-op echo showed significant mitral disease, which was not picked up in the workup echoes or the echoes pre-op. That's all I can mention about this trial. Thank you very much for attending. Yes, Paul.
What's your strategy for the two things, venous cannulation
yes.
and venting?
Yeah. So for venous cannulation, we use a flat venous cannula. We have tried both 2-stage and 3-stage. We currently use 2-stage wired flat venous cannula through the incision. So we don't go for femoral cannulation. For left ventricular venting, we use standard ascending aortic venting. When we started, we used to use the right superior pulmonary vein vent. We have stopped using that. We use a vent through the aorta itself. We excise the valve and then vent it. It can be a problem if you have a mechanical valve, and there we use a slender sucker, which is usually used for pulmonary thromboendarterectomy. That is a very small sucker which can be put in with the valve open.
Okay, in interest of time, I think we'll probably proceed, but we'll have time for discussion at the end, I think, and please take it up with Suku and the